Good afternoon, everyone. I'd like to thank Doris, James, and John for giving us the opportunity to present today. It's quite overwhelming to see so many healthcare professionals here because in the UK, if we have a primary care meeting, we normally get 6 people coming to it. So it's quite delighted. And I'd like to congratulate James on the way you pronounced my second name. Because it can sound quite rude if it's not pronounced properly. So I think you've been practicing that overnight, so thank you again for that. What I'd like to go through over the next half an hour, 45 minutes, is to give you an overview of the diabetes care over the decades and how it's moved into a model of primary care and some of the drivers for shifting this care into a primary care. I'd like to spend some time on the quality and outcomes framework. I know I've been asked to talk about that because there is a lot of interest outside the UK, especially in the US as well, of payment for performance, what it achieved and possibly what it's not achieving now. And then the new models of care, of how there is shift of care from specialist care into primary care. And then the key challenges that we're facing over the future. Primary care as a core discipline emerged in many healthcare systems, and the concept was really realized in the 1920s. However, it was when the NHS was formed in the UK in 1948 that primary care really established itself. Then it was defined by the WHO Declaration of Alma-Ata in 1978. And we all know, and you all know, that primary care is really called the gatekeeper of delivery care in the community, because we manage about 90 to 95% of the patients who come to us ourselves without any referrals, and 80% of these we resolve within a primary care setting. We know that where we have strong primary care systems, we have good practice characteristics, we have geographic regulations. In the UK, one patient is allowed to register with one primary care practitioner only, so they're not allowed to pick and choose, and I think that's where primary care seems to work well. Where we've got that system, we've got improved continuity, and there is some data coming out that improved continuity leads to better patient satisfaction and patient outcomes as well. Within a primary care setting or a community setting, you can coordinate care for that patient because we have community pharmacies, we have the community nurses, etc. And we know there's more equitable distribution in health in a population where there is primary care involvement rather than specialists who specialize in disease areas. Starfield, as you know, Barbara Starfield, who fortunately died, I think it was last year, she was a great advocate for primary care, and she's published widely on this about the structural and process elements of essentials of primary care. And really it's basically based on the accessibility, the first contact. We are, as the gatekeeper. We've got longitudinal continuity, we've got personal continuity. We're comprehensive because we don't focus on disease areas, and we have a range of services that we can divert our patients to, and we coordinate care for those patients depending on what their needs are. In terms of the UK, as I said, all patients are registered with one general practitioner. When I started in general practice in the 1990, I started on Fool's Day, 1st of April 1990 at my practice where I'm still practicing. I started as a full-time general practitioner. I used to do my own nights, my own weekends. I didn't do research at the time, then gradually moved into research. But on average, each general practitioner had about 2,000 patients. Now the average is around 1,700 to 1,800 patients per full-time equivalent general practitioners. We have groups of practices, 3 or 4 general practitioners who deliver care, but it can vary from single-handed practices to practices with 15 general practitioners. And this is where you can get super specialization within a primary care setting when you've got lots of general practitioners. We are the gatekeepers. Patients cannot access specialist care directly. Even for private healthcare, they have to come to a general practitioner, and we would refer those patients on to the specialist. And as I said, 90% of contacts are provided by us. The most important thing is general practice and specialist care is free to every patient within the UK, and it's paid through the taxation system. In terms of diabetes, why is diabetes so important? About 2.9 million people in the UK have diabetes. James mentioned it's an epidemic. When I do talks to primary care audiences, I say it's a tsunami now, especially if you look in global terms. As well as that, we've got about 6 million plus people who are at risk of diabetes, and that's an area that Simon and I work collaboratively quite a lot. It's a lifelong disease. The patient manages that disease 98% of the time. Healthcare professionals give 2% of the management in their lifetime. It costs the National Health Service millions of pounds, and it's the largest cause of acquired blindness, renal disease, and amputations. There's also financial drivers for change in the way things have shifted from specialist care to primary care, and also in terms of some of the drivers, things like the pay for performance. As I said, it's a huge health burden and huge economic burden to the National Health Service. The prevention agenda sits within a primary care setting, and now in the UK, public health and primary care, and that's where they're trying to shift management of established diabetes as well. Some of the drivers for change was because of inequalities in care, and also to improve quality of care to reduce long-term complications. Barbara Starfield's work and other people's work has shown that defined primary care systems are more cost-effective than a specialist care system. We know primary care in the UK especially is a community-based care. As I said, there are a lot of other people organising care as well, including the pharmacist who are playing a leading role in managing people with diabetes. We have a drive now to reduce unplanned admissions because that's driving the costs up. And there's a drive to improve inpatient care as well. In terms of the costs, this is from England, looking at the costs. About 11.7 million was spent on type 2 diabetes in 2010, and only 6% was on the drugs related to type 2 diabetes, and 68% was spent on inpatient care, and about 10% on outpatient care. So prescribing is talked about a lot, and I'll talk about prescribing later on. But prescribing costs the NHS very, very little compared to the complications of diabetes. So I'd like to take you to the history of how things have moved. This is where I started, I said the 1st of April in 1990. This was my practice, Winstanley Direct Health Centre. It's one of the most deprived areas of Leicester, 5th most deprived ward in England. There was a time when within a period of 13 weeks we had 8 break-ins, and they would just come and take the computers away. And as I was taking the photograph, there was a break-in in progress, as you can see as well. But when I joined, there were no diabetes registers, no structured clinics for diabetes at all. So the key drivers between 1990 and 2000 were that primary care audit groups were formed, PCAGs they were called. And this for the whole of Leicestershire population of 1 million, it was about £250,000 a year, but they made a huge difference. So we'd audit what general practitioners were doing, and then give feedback on their performance compared to their peers. And it did improve, especially in terms of the intermediate outcomes. And that was embedded over the 10-year period. Diabetes registers were established. Call recall was established because there was good evidence coming out that call recall systems for, not just for diabetes, but other disease areas, improved outcomes. And then education for GPs and nurses started to be addressed. And there were about 1.4 million people with diabetes at that time in the UK. There was, as I said, besides clinical audit, there was other quality assurance programs that were embedded within primary care systems. And then we had the evidence base as well with the publication of UK PDS in 1997. Suddenly it changed the way we were managing diabetes. I still remember in 1990, a patient would come in with diabetes for their annual review, and they usually only came once a year. And look at their HbA1c, and it was 8%, 8.5%, would say that was okay. We wouldn't manage the blood pressure or the lipids at the time at all. And suddenly, as I said, UKPD has changed the playing field completely. There were also drivers, the National Service Framework that came through, and the Quality and Outcomes Framework were brought in 2003. In terms of shifting care from specialist care to primary care, there were a few trials that were published showing that specialist care was as good as primary care in terms of HbA1c outcomes. And this was a systematic review done by a chap called Griffin, sitting in the audience here, showing that primary care could provide as good care as specialist care. Then, following on from that, we had the Quality and Outcomes Framework that came in. And so the drivers for change were similar ones that I've talked to you earlier. Here, this was a new experiment. In fact, there was a BMJ editorial on this. That this was the largest ever experiment conducted at a whole population. There was no evidence base for this at all. It was an experiment. And general practitioners were going to be paid around £8,000 for 100 points. So there would be a number of things that you'd have to do for each of your patients. And for some, 50% had to reach the targets. For some, 90% had to reach the target. And I'll show you some of those quality criteria. And main things were that you got some points for having a disease register. No one could validate whether you had how many patients were there or whether you had the true number of patients that reflected your prevalence. There was points for annual review, foot and eye screening. There were points for measuring. So within 15 months, you've measured their blood pressure, measured their lipids, measured their HbA1c. And then there were points related to outcomes. So if you reached the outcome targets, you got more points. So there were more points for outcomes than for process measures. There was Tabloid had a great time on this. And they said doctors get 20% pay rise just for doing their job. Well, this wasn't quite true. The way the Quality Outcomes Framework was negotiated was that money was taken out from what general practitioners were earning. About 25% of it was taken out. And they would get that back for reaching the target. So this wasn't new money. But what our negotiators did with the government is the government thought that general practitioners would not be able to get it all back. They thought that they wouldn't be allowed to reach targets, but they don't know general practitioners. If there's pounds attached to points, we will get them. And we managed to get nearly all the points. So this is the QOF targets have been evolving as well. Every year there's a new set of targets. They change targets. Some get redundant, new ones come in. So this is the latest targets. So there's something about the register, blood pressure. These are very loose targets compared to the evidence base, but these are audit targets. Right? 150 over 90, you get more points. 140 over 80, even more points. Cholesterol less than 5. There was a thing on microalbuminuria previously that you had to do a test for microalbuminuria. But what happened was many practices were doing dipsticks, we know is not as sensitive. So that's now been changed to annual check for albumin and creatinine ratio, nephropathy, then HbA1c targets, again graded depending what proportion who get those targets, flu vaccination, retinal screening, foot examination. These are new ones that have just come in. Annual dietetic review, referral to structured educational programs, asking about erectile dysfunction, and then advising on erectile dysfunction. As you can see, where you have the targets to achieve, you have more points than the process measure where you're just asking or measuring. The target for HbA1c changed about 3 years ago. Previously, the HbA1c, these are in millimoles per mole. Have you moved to millimoles per mole here as well? You're moving. Yeah, I'm still in the old coinage. I don't understand the millimoles per mole yet. But it was 7%, the target, that you had to get 50% of your patients below 7% to get the full points. And then there's exception reporting as well. So if you think the patient is inappropriate, patient's not, they've had 3 letters and they don't come to you, you can exception report. And this again had a lot of discussions because some GPs were exception reporting lots and others weren't. But now they've got a kite mark of what level exception reporting is acceptable at. So if you're over exception reporting, then you'll get the heavyweights coming to see you. The 7% mark was changed to 7.5% by a publication in the Lancet using routine data, which showed that patients had worse outcomes below 7.5%. This was, as I said, data using routine data, not a very good study, but they changed it to 7.5%. So at the moment, it's still 7.5%. So did cough improve outcomes? No one's done a really good evaluation of this, but there's been some secondary analysis of data. So this was published in New England by the Manchester group, and it showed basically for cardiovascular disease, there were already improvements for coronary heart disease. But when cough came in here, there was definite improvements in asthma and diabetes. So there was an indication that cough did improve management of asthma and diabetes. Then there were some systematic reviews looking at routine data which were published from the UK compared to what happened after cough in terms of targets. Intermediate outcomes had improved, and intermediate outcomes and process measures had improved as well. However, one of the ideas for cough was to improve outcomes for everyone, reduce variations in care. So this is a dot plot of every practice in England. Okay? So if you count them, there's about 8,200, I think, dots. That's each practice in England. And what this showed is this is the proportion of patients meeting a target of 7.4% or less. And it was around sort of 58%. But as you can see, it was variable. There were some getting to the 100%, but there were others at around 20%. But the larger the practice, the less variation there was in terms of achieving these targets. So we looked at this with my colleagues in Imperial College, especially Chris Millett, who I work with. I'm sorry, there's something wrong. It's not coming out here, and it didn't come out in my computer as well. But what this shows is this is by deprivation, and this is by size of practice. There was a lot of talk that deprived patients get worse outcomes, and single-handed practices are not as good as large group practices. And there was a government drive to reduce the number of single-handed practices and increase the number of group practices. So this is increase in deprivation. So this is the most deprived. This is the least deprived. And this is the size of practice. This is single-handed practice. This is between 2 and 4 doctor practice, and this is more than 4. And what we've found that is single-handed practices in deprived areas had the worst outcomes in terms of intermediate outcome. However, single-handed practices in affluent areas were the best performing. So single-handed per se is not a bad thing. And in the same way, practices that were large practices in deprived area did reasonably well as well. The other reason for getting cough was to reduce variations in certain ethnic groups as well, because it was felt that certain ethnic groups weren't getting the quality of care. So we looked at this with Chris's group, and this showed that in terms of all targets being met following the quality outcomes framework, South Asians didn't get as good care as white Europeans. We also looked at insulin, because if you're going for tighter targets, you need eventually to put people onto insulin. And South Asians, for various reasons, don't like going onto insulin. And again, we looked at before and after cough, and the analysis showed that South Asians were 50% less likely to go onto insulin following cough. So in terms of variations between minority groups, they didn't change because of cough. So in terms of summary up to 2000, we found that NSF targets in respect to diabetes care were being met, the National Service Framework target. NICE guidance also started coming in and set standards of care. QOF had an impact in terms of delivery of diabetes care, especially the process measures and intermediate outcome measures. And primary care was demonstrating significant improvements following introduction of QOF. The number of people by 2010 was around 2.8 million people in the UK. In terms of the next decade, they've started thinking about what else, what next. But there's still variable care, and in terms of service provision and outcomes. There's more about patient empowerment for prevention and management of diabetes. So there's reasons, because 98% of the time that patient is managing their diabetes. However, the reason structured education program came in the last year's targets for this year's target for QOF is because only 11% of people were getting a structured education program. So they feel that by putting it into QOF, more people will get structured education. But there's a lot of debate. What do we mean by structured education? And Simon may talk about that. But structured education, as far as QOF goes, it's just a tick box exercise. So you see the patient. For measurements, it's fine because you can put the measurements in. You can't cheat on blood tests because they come directly from the lab into the computer system. You could have variable hearing or variable machines when you're doing blood pressure targets. And in terms of structured education, the NICE standards have said that you need to have quality assured structured education programs that have the psychological underpinning and have shown to improve outcomes. But lots of areas are making up their own structured education programs, and you get a tick box for referring the patients. Then we've now got commissioning of services in terms of developing primary care to look after people with type 2 diabetes. There's changing role of the specialist care and emphasis on collaboration and integration of care between primary and specialist care. And the reason for this is feel specialist care cannot manage the number of people predicted to have diabetes. So this is the prevalence atlas for England and Wales. So this is a proportion of patients. This is a prevalence of more than 9% having diabetes by 2030. There are some areas already have a prevalence in that region, and this is the Leicester area, some of the London boroughs that have a prevalence of about 8 to 9%. But that's what people are worried about. There is no way we'd be able to cope with a specialist care service delivering care to so many people with type 2 diabetes. In terms of where care is delivered, this is really old data in the 1990s, 1998. At that time, about 63% were being looked after solely in primary care, around 12% in specialist care, and about 24% shared care. Our feeling was these people got the worst deal because they thought, secondary care thought we were looking after them in primary care, and primary care thought secondary care were looking after them, so they were probably not getting a good care. The new models are changing. So most places now are saying that 95% should be looked after in a primary care setting, and only 5% in a specialist care setting. And in some places they're going even tighter, that 3% should be looked after in a specialist care setting. And some of these people who are making these decisions don't know anything about diabetes at all. These are what we call the man from Sainsbury's, who just look at the pound signs, that it's cheaper to manage patients in a primary care setting. There is big issue about shifting everyone into primary care because we know that patients get admitted for complications if they're not well managed. So this is what's costing the NHS a lot of money. 15% of diabetes accounted for 15% of bed days in a hospital. Median length of stay for someone with diabetes is 8 days compared to 5 days for someone without diabetes. And those who are being admitted, 40% are on insulin. If we say about 22-25% of people with type 2 diabetes are being looked after and are on insulin, I don't think we've got the expertise in a primary care setting to manage people with insulin. And is that the reason why many of these patients are being admitted? I don't know. I don't have the answer to that. So we used to have primary care trusts, small organizations which looked after an area. So in my area, we had one primary care trust looking after the Leicestershire. Now we've got commissioning groups that have come in. So the people who are going to hold the budgets are going to be primary care. And they're directing and delivering and organising the care people with chronic disease will get, including diabetes. And this was the King's Functioning an approach. Commissioning is an approach that seeks to improve quality of care for individual patients, service users, carers, ensuring that services are well coordinated. So it was all about coordinating the care. And they felt that primary care is, for all the reasons I've said, is a better person to coordinate a person's care than specialist care. So I'm just going to go through a few models that have cropping up. So there are various models of looking after someone with complex diabetes care. Just to give you an example for insulin. So there are 3 possible ways that you can start insulin. You could be in a practice that you've had the training, the general practitioner and nurse have the training to initiate insulin and up-titrate. You could have patients being referred to hospital where the consultant sees them with the nurses and start insulin and up-titrate. Or you can have a middle house, a community care model where there could be a GP specialist with a nurse, or if you don't have a GP specialist in the area, a consultant who comes into the community. Because again, if you look at the evidence, it shows that patients want to be managed in a community setting rather than a hospital setting. There's quite a lot of data on that. So this is one model, and I must thank Simon for sharing this slide with me. This is Partha Carr, who's a specialist in Portsmouth, down south. He's developed this model called the Super 6. So this is specialist responsibilities in the hospital are endocrinology, acute medicine, and Super 6. Insulin pumps, antenatal diabetes care, diabetes foot care, people who have dialysis or low eGFR, uncontrolled type 1 diabetes, adolescent diabetes, and inpatient diabetes. And they have the way they've done it is they have a defined budget, which they've worked with primary care. This is what we've got, and this is what we can deliver within that budget framework. So they have daily designated telephone calls with GPs. So GPs can phone directly in, say, I've got a problem with this patient, or their HbA1c is such and such. I'm not sure about this new SGLT2 receptor agonist that have come through. I understand that you start peeing a lot of glucose. Is that good for you? Should I be starting on them? And then they will give them advice of what's the most appropriate therapy for that patient. There's email access as well. And there's visits to the GP surgery. And this is for 2 reasons. One is to try and help them manage complex patients. And secondly, as a mentorship program, so you're improving and upskilling those nurses and GPs in those practices. So this is one model, and it seems to be working well. They haven't got a huge amount of data looking at outcomes yet. We've, in Leicestershire, done a similar thing. We have a much larger population. We have 3 CCGs. So we're working with what's called a transformation program. So working with the CCGs, the Leicester Partnership Trust, the University Hospitals of Leicester, Leicester City and County Council, because that's where the prevention agenda now sits. And also I should have put down University of Leicester as well. And the way we're trying to do it is that level 1, this is 70-80% of the patients who are not that complex, who are on diet, metformin, maybe second-line therapy, 2 oral drugs. Anyone could manage that in a primary care setting. You don't need those patients to go to a specialist. Then specialist disease management, this is where you may be thinking about starting injectables, insulin or GLP-1 receptor agonists. And then finally, the highly complex patients, which would then go to a specialist care. So this is the model we're working on. We've called it the Super 6 and the Necessary 9. We always have to be better than someone else who's done it. So Super 6 is very similar. This is what specialist care would look after. There is integrated care and people moving between there. This is the essential primary care, which is, as I said, the simple patients who may just be newly diagnosed or 1 therapy or possibly 2 therapies. There's also district nurse support and a medicines management program across the integrated care. And then there are some practices, and this is a pilot, so there are 9 practices at the moment who are becoming, not as GPs, but as a practice becoming a super specialist practice. The criteria are, there are competency criteria. One criteria is that one person, at least in that practice, should have done an MSc in diabetes. And what they do is screening, prevention, regular review, prescribing insulin, GLP-1, structured patient education. They may either be delivering it in their program or at least referring cardiovascular risk management, management of housebound and care home patients, and they're doing regular audit and outcomes. They get feedback on a regular basis. They have a mentorship program as well. The other thing, what we've done in our locality is we've got clinical practice, research and education all working together. So we've got this huge program called the Eden program. That's just in the city of Leicester. So our group at the university are trying to upskill every practice. There are 60 practices looking after something like 30,000 patients within that small 1 CCG area. Every practice will be upskilled to a level that they can initiate and up-titrate injectables. So this is insulin and GLP-1 receptor agonists. So this is sort of, we do a lot of research in this area. We giving them the education. They come to our department to get the education. They get a mentorship program. And over the next 3 years, they will also get outcome data presented to them on a regular basis. Ultimate aim is that we have improved outcomes for these patients at a lesser cost because we're not referring them into a specialist setting, and we're trying to manage their treatment at much earlier in their disease trajectory with the hope that they will have better outcomes later on. And this is being evaluated as well. Every practice gets time out. They get backfill money. So this is what CCG, because CCG have the money, they can do this now. They said this is an important area. We have 40% in our area of people who are of South Asian origin. So our prevalence for diabetes is much higher. Their complications are higher. They die earlier. So they've invested in this area. So they get regular updates as a mentorship modules that they come to, not just their nurses, but the healthcare assistants as well. Now, just to go through over the next few minutes on the challenges for the future. This is the number of GPs staying static, but the number of consultants is increasing. But we're being landed with all the work that comes to secondary care. It's all coming to us, and it's becoming really unmanageable now. Morale is very, very low in primary care at the moment because of shifting of care into primary care. It's fine if you have the manpower to do it, but if you haven't got the manpower, you can't soak everything up. I've given you 2 examples of areas it's working well. There's integration of specialists and primary care. But most areas are not working that way. There's a lot of divide. They're not sitting at the same table trying to coordinate and develop care pathways for an integration of care. QOF, I think, has reached this sell-by date personally. This is 9 care processes. So these are 8 proportion who've had these measures done. They've taken retinopathy out of that now. But as you can see, most are plateaued now. There's a few increasing, but majority of care processes are plateaued. There's still huge variations. So this is I showed you the mean. These are the ranges between practices. So still huge variations in care. This is published using routine data on an annual basis. So we get this data per CCG on an annual basis. And you can even check where your CCG is. Not just you could sit here and check what my CCG is doing, because this is all publicly available data. This is the proportion getting the 3 targets, BP, lipids, and HbA1c. And as you can see, there is huge variation, and not everyone is getting all the targets achieved. This is the intermediate outcomes. Again, huge ranges, not as large as process measures. So this, for example, is cholesterol of less than 4 millimoles. 40% are achieving this, but it could be between 30 and 50%. Same with blood pressure targets. So there are still variations. Some data showing that variations have narrowed, but there are still huge variations. There's variability in care. This is the 9 process measures. The lowest rates in the grey and the highest rates in the dark blue. And these are amputations in England. Huge variations in amputation rates between the countries, between the regions. Going forward, we're going to have more problems in terms of our elderly population. Multimorbidity, it's called. So this is diabetes, and this is the comorbid conditions that these patients have. 23% have coronary heart disease, 54% hypertension, 21% depression. So multimorbidity is increasing, and you can't work on disease areas. You can't just say it's a diabetes clinic. So now we're, for example, at our practice, and some are starting to say this is a vascular clinic. So people will have had a stroke or an MI and a CKD and HbA1c, and diabetes, they'd be called in at one sitting to look at all their risk factors. And again, this is adding complexity. Prescribing is under scrutiny because prescribing rates are going up, but although they're going up, the prescribing cost is minimal compared to complications. So this is the prescribing cost. This is analog insulins. The evidence base, as Nice said, was not that strong, but the pharmaceutical companies are doing a fantastic job. So analogs are increasing. If you look at the other insulins, they're going down. This is mainly NPH. This is sulfonylureas, again, very plateaued because the new drugs are coming in and more people are using the new drugs. This is an area that we're interested in. That we have a huge evidence base, but we're still not managing our patients well. So this is looking at if you're on 1 oral drug, 2 oral drugs, or 3 oral drugs going on to insulin. If you're on 1 oral drug and your HbA1c is above 7.5%, it takes median of 1.5 years before we put them onto a second oral drug. If they're on 2 oral drugs and their HbA1c is greater than 7.5%, it takes a median of 7 years before we up titrate. And if you are on 3 OADs and you're going to insulin, it takes a median of 6 years, despite having HbA1c above 7.5%, before going on to insulin. We're waiting far too long, and most evidence shows that you need to go tighter much earlier on to reap the benefits later on. So in summary, I think management of diabetes is complex and multifactorial, and the NHS landscape, as I showed you, has changed over the last 20, 30 years that I've been in practice. Primary care is being upskilled to manage this increased prevalence of diabetes, but I think not all is good. We have to be cautious of shifting all the care there. It's a major focus for NICE, the National Prescribing. We have QIP targets on saving from drugs. And the specialist team, I think they are feeling vulnerable. Their role is changing drastically compared to when they were trained to become endocrinologists. Thank you very much.